A new study examining the impact of ketamine on depression may offer some optimism for treatment-resistant patients, but it also casts a long shadow over the consequences of chronic opioid use and reveals a deeper, more disturbing vulnerability in how the human brain is responding to modern medicine. While ketamine may still provide measurable antidepressant effects even in people with a history of opioid use, the study highlights something far more alarming: the extent to which long-term opioid exposure appears to deaden the brain's natural healing capacity, eroding one of the most powerful tools in psychological treatment, the placebo response. The study, published in the Journal of Affective Disorders, involved patients undergoing surgery who were either given ketamine or a placebo to observe changes in depressive symptoms. What the researchers found is unsettling. Individuals who had used opioids chronically responded poorly to the placebo, showing little to no improvement in depressive symptoms. Meanwhile, those same individuals responded to ketamine about as well as non-opioid users. At first glance, this may seem like a win for ketamine as a medication. But dig deeper, and what emerges is a warning about how extensively opioids may rewire the brain's neurochemical architecture, dampening hope, muting expectation, and stripping away the brain's ability to benefit from belief itself. Opioids are known to hijack the body's reward systems, distorting the natural production of endorphins and other mood-regulating chemicals. Over time, they don't just mask pain, they reshape emotion, dampen pleasure, and potentially suppress the subtle interplay between expectation and biological response that defines the placebo effect. This isn't just a clinical curiosity. It's a serious public health problem. It suggests that millions of people who have been prescribed opioids, sometimes unnecessarily and often for prolonged periods, may now have a fundamentally impaired ability to respond to therapeutic interventions, not just chemically, but psychologically and neurologically. This casts a chilling light on the overprescription of opioids across Europe and the United States. Pain relief has become a gateway to emotional flattening, not just through addiction, but through deeper, longer-lasting damage to mental health resilience. If the placebo response, something that has been shown to account for significant portions of improvement in depression trials, is being quietly dismantled by long-term drug use, then entire segments of the population are being rendered biologically less able to recover from mental illness. That should terrify anyone paying attention. Even ketamine, the supposed bright spot in this study, is not without its darker implications. While it may still work where placebo and traditional antidepressants do not, ketamine itself is a powerful psychoactive substance with the potential for misuse, dependency, and cognitive disruption. It's already being overpromoted in some circles as a miracle cure for depression, when in reality, its long-term effects are not fully understood. Used improperly or without careful monitoring, it could simply become another crutch in the pharmacological cycle of numbing symptoms rather than addressing root causes. And yet, ironically, ketamine's efficacy in opioid-exposed individuals raises a disturbing philosophical question. Are we entering an era where we must bypass the brain's own healing mechanisms because they've been chemically blunted? Will future treatments rely less on boosting natural resilience and more on brute force interventions that temporarily simulate relief, without fostering real mental recovery? If the placebo response, a complex dance between biology, belief, and context, is being stripped away by common medications, what does that say about the direction psychiatry and mental health care are heading? The study should be a wake-up call. It demands that researchers and clinicians reconsider not only how depression is treated, but also how prior medication history, especially opioid exposure, might sabotage future treatments. It challenges the assumption that all patients are starting from the same psychological baseline. In reality, some have had their emotional and cognitive ecosystems so radically altered by long-term drug exposure that conventional therapies, including talk therapy and even hopeful anticipation, may no longer have any measurable effect. The cost of this isn't just measured in research outcomes. It's measured in human lives. People who can no longer feel joy, hope, or connection because their neurochemical balance has been suppressed for too long. People who fail to respond to therapy and medication not because their depression is more severe, but because their bodies have been trained to suppress the very responses that therapy relies on. This is not a failure of character or willpower. It is a systemic failure of the way we approach chronic pain, mental health, and the over-medicalization of both. Yes, ketamine may offer a short-term solution for some, but the broader warning is clear. The path we are on, dominated by pharmacological quick fixes, is eroding the very faculties that make healing possible. We are medicating away not just pain, but the mind's ability to recover. And unless there is a radical shift in how we prescribe, monitor, and understand these substances, we may soon find ourselves treating symptoms in patients whose capacity for recovery has already been chemically dismantled.